So our final speaker of the day is Dr. David Bushnell. He's over at the University of Iowa, along with several of the other speakers that you saw today. And Dr. Bushnell is going to share his knowledge and experience on the topic of what's the latest in PRRT. So, Dr. Bushnell, welcome.
Thank you, Bob. I see on my screen there we go. I saw the poll there, and now I see my standard welcome to Iowa. If you've never been to Iowa, this this is we have a lake that's about a mile from my house. This is of course not Iowa. It's Florida, but in any event, welcome. I'm always privileged to have an opportunity to speak with the patient groups. Such a great meeting. Thank you, Bob and Marianne. Thank you to the technical people. As my goodness, they had great patience with me here last night as well, and so thanks again to them. Just as a quick aside, you may notice I'm wearing a jacket. It's the Midwest, and in the winter it's rather cold out. You say, well, you live in a house, so why are you wearing a jacket? Well, as it turns out, we do have a furnace. But also turns out that there was a bit of a gathering of mice. One of the air ducts a few days back, and apparently only a handful made it out alive, and so unfortunately, when we turn the furnace on, we sort of have I apologize. Look at that, and it's spam. So our furnace delivers a rather unpleasant deceased mouse throughout the house. So that's why I've got my winter coat on here. So let's go ahead to the next slide. About 20 years ago, we were involved with clinical trial. Terrific presentation by the prior two speakers from University of Kentucky, and talk to you a little bit about the clinical trials, which I know you're all very familiar with, concepts of phase 1, 2, 3. And this was a phase 2/3 trial that was conducted by Novartis about 20 years ago. And some of you will remember this trial perhaps. And we participated in it, and the tracer and the targeting agent were the therapeutic agent Y90, a little bit different than lutetium DOTATATE, quite similar to DOTATATE. And this, I always love this case. You could see that the baseline CT with the tumors here in the liver, and the follow-up CT after 3 cycles of the yttrium-90 DOTATATE demonstrated a terrific response. It was classified as a partial response because there was still a little bit of tumor. And as the last speaker pointed out, in the older days, we used indium pentatreotide. You all know it as Octreoscan, and you can see the targeting was quite good in some of the tumors. There was also targeting in an area where the liver was essentially normal on CT, but that represented a reflected tumor presence at that point. So a great response, but unfortunately, as we know, yttrium-90 DOTATATE did not receive FDA approval. The FDA did not like the idea that there was not a comparator arm, control arm, if you will, in this study. So there was a bit of a bleak period where in the U.S., patients, if they wanted to get treated with PRRT were required to go to Europe, and many of our folks at the University of Iowa with Dr. Odoricio did in fact do that. However, a smaller group, Advanced Accelerator Applications, began a trial with lutetium dotatate that you're all now familiar with as LUTATHERA, and published the results 3 years ago in a pretty famous paper in the New England Journal. And as some of the prior speakers demonstrated, we've seen terrific results with LUTATHERA for treatment of these tumors. Here's an example of one of the patients that we treated in that trial at Iowa. The blue circle shows this kind of bilobed pattern of uptake on the gallium dotatate scan, and you can see the corresponding low density tumor defect on the CT scan, and just a terrific response. I mean, this particular tumor site demonstrated complete response. Now, on the other hand, the smaller tumor site did demonstrate still some residual tumor. So LUTATHERA is great, and it's been very helpful for many patients. But how do we do better? And what's on the horizon? What's coming up here to improve the safety and effectiveness of PRRT with LUTATHERA or other agents? And I've made a little list here. Selection criteria based on PET might help us to improve identifying patients that are likely to respond really well. Combining with chemotherapy, you heard on the prior speaker talk about a number of trials, quite a number that are ongoing in this country, combining LUTATHERA with chemotherapy. Some investigators have initiated the potential for using both lutetium and yttrium. Yttrium sort of works better for bigger tumors, and lutetium works a little better for smaller tumors. Adding an entirely different sort of targeted theranostics agent, the recently approved MIBG molecule labeled with I-131 is known as AZEDRA. And hepatic artery injection, an interesting possibility. And I'm going to really touch on a couple toward here the bottom in red, the dosimetry and the alpha particle emitter treatments, I think hold perhaps maybe the greatest potential for improving things. It's probably a little unfair. I'm a little biased because those are the areas of our focus. But dosimetry and alpha therapy, a lot of reason for optimism with those approaches. So what about dosimetry? This concept that everybody is the same, and everybody should be treated. Every patient should be treated with the same amount of a radiopharmaceutical, LUTATHERA in this case. Didn't really make a lot of sense to many of us in the field for a long time. Here's a editorial that was published 3 years ago in a terrific journal from Europe. The authors concluded, we believe that to adhere to the optimization principle for oncologic patients, that nuclear medicine therapy needs to be individualized based on dosimetry. And personalized medicine really demands that we do patient-specific measurements. All patients, as I'm sure you all know, are in fact not the same. And again, this was actually earlier published by Dr. Strigari way back 6-7 years ago. And even at that point, it was pretty clear that there was enough evidence, a correlation between the radiation absorbed dose and tumor response or normal organ toxicity that it clearly indicated the importance of dosimetry-based personalized approaches. Well, in fairness to industry, I mean, it's tough. It's not easy. You know, it's more expensive. It's a bigger hill to get over, and but we're trying to work together with industry to move a little bit more in the personalized dosimetry direction. You know what? For those of you, you know, dosimetry, what is it? With radiopharmaceuticals, there's this great advantage that you can give a little tiny amount of that radiopharmaceutical, and you can measure how much radiation the big therapeutic amount to come later is going to deliver to the tumors and to the normal organs. The word dose, you know, so it can be confusing because we'll sometimes talk about, well, what dose of LUTATHERA should we give the patient? 200 millicuries. Well, in truth, the term dose in that context is rather misleading. Dose, as we know it in radiotherapy, it represents the amount of energy that a radiation type deposits in a tumor or an organ. So amount of energy, and then it's normalized for the mass of the organ. Now, if we look at patients as individuals and we look at them in terms of how they differ from the amount of radiation energy that goes to the tumor or say to the kidneys, here's a study that said, yeah, let's take a look at that. And what they found was they said, well, all right, we're going to treat every patient so that the amount of energy deposited in the kidneys of those patients is 27 units, and the unit they use is G, or we use is GY. That's a gray. This is the standard. They did the standard fixed administered activity of 200 millicuries each cycle, as we know, is the FDA approved approach to LUTATHERA treatment. And then they published this work, and here's the graph on the x-axis. These are the number of cycles that the individual patients received of the 200 millicuries that delivered this much radiation to the kidneys. And what they found is that the large majority of patients can receive 5 or 6 cycles of 200 millicuries safely without risk of significant toxicity to the kidneys from the radiation deposited. Well, as I mentioned, you know, it's hard. Dosimetry has been a tricky thing for the last 10, 15 years. We certainly have been active with it for over a decade, but it does require more time from the patient. It's more expensive. But this is a sort of ugly slide. Just look at the title, single time point. So whereas in the past we've had to make measurements on patients day after day after day, now it's beginning to be clear to us we can simplify dosimetry so that we can make the individual measurements with only one, make the individual dose calculations with only one measurement. Much easier, much simpler. All right, let me switch to a quick mention of antagonists versus agonists. So LUTATHERA is a lutetium labeled molecule that we consider to be an antagonist. When it binds to the somatostatin receptor, it actually, if it were given in larger amounts, would sort of activate the cell to do certain things. On the other hand, it turns out an antagonist, as you kind of sounds like, when it binds to a somatostatin receptor, it sort of turns off the what the receptor would tell the cell to do. And because of that, it turns out that for the antagonist molecules, there are a greater number of SSTR somatostatin receptors available for that molecule to bind to. And there are clinical trials now ongoing with at least one that I know of, antagonist lutetium labeled agent. How about directly? What about if we, took patients who had predominantly liver disease, and of course many folks do, and we just injected the radiopharmaceutical LUTATHERA directly into the hepatic artery. So we'll go right into the hepatic artery. So the interventional radiologist would put a catheter up the aorta and then into the hepatic artery, and then a nuclear technologist would inject the LUTATHERA. Well, as it turns out, that's a pretty promising approach. And I think I have on the next slide, this was a study done about 5 years ago, and a group took patients, a small number of patients with liver-dominant metastatic disease, and they injected and this actually is Octreoscan, injected Octreoscan through the vein, the usual route. Then they took images. Then they brought the patient back the following week, and they put a catheter up into the hepatic artery, injected the same amount of Octreoscan, and then they compared the images. And what they found, if you look, you can see here's the image of the uptake of the octreotide agent with an arterial injection. And look at the difference in uptake here. Some tumor sites, such as these two and this one, are barely even visible with the intravenous injection. So much better targeting. Well, what is much better? These authors found that you could see a factor of 4 times more uptake with the intrahepatic injection, the artery, than with the venous injection. All right, well, what about adding another radiopharmaceutical theranostic agent that has a radioactive iodine? People are perhaps familiar with radioiodine for treatment of thyroid cancer. Well, put that radioiodine onto a molecule that targets a different receptor than the somatostatin receptor, and importantly, has a different critical organ, that is the organ that we're most concerned about in terms of toxicity, compared to, in this case, we had the PRRT agent was yttrium-90 DOTATATE. It was the same for LUTATHERA, although with LUTATHERA, there's a little bit more crossover between the two organs. Combined the radiation delivery of those two different radioactive drugs to enhance the amount of radiation delivered to the tumor. And the clinical trial that we've had ongoing for several years, number of years, started out with yttrium DOTATATE. Now we're moving to a trial design that's a little bit more practical. Patients are given the standard of care, 200 millicuries of LUTATHERA. We add a little tracer amount of the radioiodine agent. We do the imaging and dosimetry afterwards, and if the AZEDRA images show tumor targeting as well as the LUTATHERA, then we go into a different treatment arm where the two agents are delivered together. On the other hand, if AZEDRA doesn't target, and about 50% of patients don't, 50% do, the individuals simply go on and continue standard of care LUTATHERA treatment. Well, some great comments, some terrific slides demonstrating with the last speaker the comparing FDG PET, good old FDG PET, around for 20 years, many kinds of tumor types. It's non-specific to a much greater degree than DOTATATE. And here's an example of a high-grade tumor in a patient. This, if you're familiar with the Ki-67, that number, many of you probably are. This patient had a Ki-67 of around 30%, and the DOTATATE study was really pretty minimal in terms of the uptake. There's a little bit of uptake in some of these tumor sites, but then when you come to, oh, and I apologize, this isn't FDG. Sorry, I'm going to confuse you. Forgive me. This is not FDG. This is a different receptor altogether that turns out to be more highly expressed in these higher grade tumor types. A little bit like FDG, the pentixafor tracer agent sort of parallels the degree of uptake of FDG, and it's opposite in uptake pattern compared to DOTATATE. And Dr. Mende at our facility has been doing a lot of good work with pentixafor. This can be a little bit much. The pentixafor targets this receptor, CXCR4. So the CXCR4 receptor, unlike somatostatin receptors, is high in the grade 3 tumors. The somatostatin receptor is depicted by the red line here, and the CXCR4 receptor and these neuroendocrine tumor cells depicted by the blue line. You can see it's higher in these higher grade than the DOTATATE receptor, somatostatin receptor is. I'm going to skip this. As I said, the previous speaker spoke so wonderfully about FDG versus DOTATATE. These are cases where the idea of combining chemotherapy makes great sense. You have sort of modest DOTATATE. You have a lot of FDG positivity. But let me go and mention a new approach that I think carries a lot of promise. It's really pretty new. I think there are some trials initiated, perhaps early phase. When we radiate a tumor cell and kill it, what we're doing is breaking apart the DNA of the tumor cell. Now, of course, unfortunately, we do break some of the normal cell DNA as well. But breaking the DNA of the tumor cell, sometimes the tumor cell can repair that DNA break, and then the cell lives and kind of goes on and does its bad thing. Now, if we could inhibit the repair process so that the break we induced with the radiation ultimately led to enough damage in the DNA that the cell died, that'd be a great thing. And that's where PARP, you may hear this term PARP, and it's a type of enzyme essentially that helps repair these breaks. And if we could inhibit the PARP agent, PARP enzyme, we could diminish the tumor cell's ability to repair the break. And so that combining PARP inhibitors, in other words, DNA repair inhibitors, with radioactive agents like LUTATHERA, radioiodine, will be a big part, an important approach to study in the near term here. All right, now let me spend the last few. So this is what I think is big and really exciting. Alpha particles, and you probably, many of you have heard about it, this concept of using an alpha targeted radiotherapeutic. It's a big particle relative to the beta particles from LUTATHERA. Instead of sort of little breaks, the alpha particle makes big double we use the term double strand breaks. One alpha particle breaks many times greater than thousands of beta particles. So the idea has been around for a long time, but there are many obstacles. One of the great things about alpha is that it deposits this big amount of energy in a very short radius. So inside the tumor, if you look at this slide, the orange balls are reflective, supposed to reflect the tumor. The gray reflects normal tissue around the tumor. And yttrium-90, for example, beta emitter, the electrons actually go far enough that they can get out and damage the normal cells. On the other hand, bismuth-213, an alpha particle emitter, delivers alpha particles that only go far enough to kill a few, get to a few tumor cells, and the normal tissue around the tumor is spared. This was a series of 8 patients published back already 6 years ago, but the work was done 10 years ago. Small series. Interestingly, most of these patients were actually injected intrahepatic, but there were 1 or 2 that were IV injections. And all 8 of them had failed or relapsed following treatment with LUTA or Y90 TOC or TATE. Here's an image after the failure, gallium DOTATATE or DOTATATE image. Lots of big tumor tissue that's still there after LUTATHERA. But now look at after 2 treatments with bismuth, same targeting molecule, but now it's a bismuth. So we fire that alpha. Look what happens to the tumors. Really remarkable. So let me go here. So let me turn now to an alpha particle emitter that we've been working with for the last 5 years or so. Mike Schultz has one of our collaborators has a big preclinical lab that he's given us tremendous information, and we're now funded for a phase 1 clinical trial with lead, an octreopeptide with lead. Lead does emit beta, but it also emits in the process of decay 2 alpha particles. Now, as it turns out, and many of you may know this, Radiomedics has already completed a phase 1 trial with alpha lead-212 emitter labeled with DOTATATE. Alpha Medics is the word they give to this combination. And Dr. Del Pisan was gracious enough to share some slides that I can present to you. And you can see here's an example. This is a patient with a atypical carcinoid, metastatic disease. Their trial a little bit different than ours. These are patients that have not been treated with a LUTATHERA or Y90 agent to this point in time. But now look at the dramatic regression of tumor after several cycles of the lead-212 alpha medics. And because it's just so terrific, I'm going to show 3 of his cases. Here's another case. I believe it was a lung. So lady with bronchial carcinoid, atypical, I believe. You can see the extensive tumor prior to therapy in the chest. After 1 cycle, look at this. Look at this. Just remarkable, dramatic response. Here's another. It's not just one. It's not just a rare event that we're seeing with the alpha emitter eliminating grossly, at least, tumor. This is a patient here with liver metastatic disease from a small bowel tumor. You can see the small tumor sites on this gallium pre-therapy. And then after 4 cycles, look at the tumor pattern here in the liver, we just don't see anything on the gallium study. Alpha therapy, to me, holds the greatest potential for large impact. Now, it's probably maybe the most challenging with the most obstacles. So big upside, but lots of obstacles, and maybe, although we don't know for sure, but maybe there's risks that, you know, we're thinking about and we're considering, but the risks may be high as well. And so with that, this is a crazy slide. I refer to it. It's our trial design at Iowa for the Lead-212 phase 1 study. This is really all I wanted to show you, is that we have this study ongoing at Iowa. And with that, let me finish up. Bertrand Russell, the world is full of magical things. They're patiently awaiting for our wits to grow sharper. So I know my family's been waiting a long time for my wits to grow sharper. I'm not sure that's going to happen, but we've got a lot of great things for neuroendocrine treatment, I think, that are on the horizon. And I thank you very much. It's always a pleasure to speak at these meetings. And Bob, forgive me if I may have been a little bit past my allotted time.
No, thank you, Dr. Bushnell, and thank you for being so perseverant, so that you got through your personal trials here. Thank you for being here today. You know,
it's a testament to your fabulous technology team, the patience that they exercise.
Yeah. Well, you know, it's the way we got to do it nowadays.